a phase 3 study of buparlisib and fulvestrant in postmenopausal women with hormone receptor positive, HER2 negative, and aromatase inhibitor treated locally advanced or metastatic breast cancer who progressed on or after mTOR inhibitor based treatment. You got it.
Thank you.
It will be presented by Dr. Ruth O'Regan from the University of Wisconsin. Ruth.
Thank you, Carlos. Good morning, everyone. It's my pleasure to present the results of BEL-3. Dr. DeLeo will present the full presentation this afternoon. So the rationale for BEL-3 is shown here. So basically what we know is that with current mTOR inhibitors, such as everolimus, there's a feedback that activates the AKT pathway. Further, what's been shown is that the use of PI3 kinase inhibitors can abrogate and attenuate this activation, potentially blocking that pathway. So the hypothesis of BEL-3 was that by using a PI3 kinase inhibitor, it might be effective in hormone receptor positive breast cancers that are resistant to mTOR inhibitors. So here's the study design for BEL-3. It accrued postmenopausal women with hormone receptor positive HER2 negative breast cancer who'd been treated with prior aromatase inhibitor therapy. What's different between this trial and other trials you've seen is that all patients have progressed either on or following treatment with an mTOR inhibitor. Prior fulvestrant was not allowed on the trial. There was over 400 patients randomized 2-to-1 to receive fulvestrant at the 500 milligram dosing schedule plus buparlisib, the PI3 kinase inhibitor, or the control arm, which was fulvestrant plus placebo. The primary endpoint was progression-free survival. Secondary endpoints include overall survival. Other secondary endpoints include outcome based on PIK3CA status of both the primary tumor and by ctDNA. As far as prior treatment shown here, all patients had prior mTOR inhibitors, as you can see shown here, and the majority of patients have progressed either on or within 30 days of receiving an mTOR inhibitor. You can see the median duration of the mTOR inhibitor prior to going on this study, as you can see, was about 8 months, 8 to 9 months, as you can see. As far as other treatments, almost 70% of patients had received at least 2 lines of endocrine therapy in the metastatic setting, and a third of patients had received chemotherapy in the metastatic setting. As far as the patient disposition and treatment exposure shown here, what you can see is that there were more dose interruptions, dose reductions, and treatment discontinuations in the buparlisib arm compared to the placebo arm. But you can see that the on-study deaths related to treatment were the same on both arms and rather low, as you can see shown here. So here's the primary endpoint, which was progression-free survival per investigator assessment. BEL-3 did make its primary endpoint in that there was a significant improvement in progression-free survival from the control arm of about 2 months up to 4 months in the buparlisib arm. This was statistically significant with a hazard ratio of 0.67. You can see the curve split fairly early in favor of the buparlisib arm. Other endpoints that were looked at were response rate and clinical benefit rate. You can see the response rate was low in both arms, but it was higher in the buparlisib arm. Likewise, clinical benefit was higher in the buparlisib arm. Looking at the forest plot of different subgroups shown here, you can see that the majority of groups that were predefined did benefit from buparlisib compared to the control group. Just to note at the very bottom of this slide, the sensitivity to prior mTOR inhibitor treatment. What was interesting here is that the patients who did not benefit from endocrine therapy and mTOR inhibitor prior to going on this study actually did benefit from buparlisib, which supports the idea that the PI3 kinase inhibition may be useful in cancers that are resistant to mTOR inhibitors. Now, from previous data, what has been suggested is that the PI3 kinase inhibitors may be more effective in cancers that have PIK3CA mutations. So this was assessed in 2 ways in this study. First of all, in the primary tumor using PCR, and secondly, in circulating tumor DNA, which has been done previously as well. What you can see here is that about a third of cancers were considered PIK3CA mutants, either looking at the primary tumor or at the ctDNA. And in both of these cases, you can see buparlisib the buparlisib arm was superior to the control arm. As you can see that in both, whether you looked at the primary tumor or the ctDNA, there was an improvement in progression-free survival with buparlisib compared to the control group. In the tumors that had wild-type PIK3CA, if you looked at the primary tumor, there was no difference between the arms. However, if you looked at the wild-type tumors based on the ctDNA analysis, you can see there still appeared to be a benefit for buparlisib over the control group. The other thing that was noted on this study was if you broke down the patient based on whether they had visceral or non-visceral disease, shown here, you can see that it was the patients with visceral disease that benefited from the PI3 kinase inhibitor, shown on this slide. And in patients with non-visceral disease, there was no difference between the two arms of the study. As far as adverse events, this is looking at adverse events that were seen in greater than or equal to 10% of patients. There was more adverse events in the buparlisib arm compared to the control arm. As you can see, as has previously been reported, there was increased transaminases and also psychiatric issues like depression and anxiety, and there were a few patients that attempted suicide on the buparlisib arm. So in conclusion, the BEL-3 trial met its primary endpoint with buparlisib and fulvestrant prolonging progression-free survival compared to placebo plus fulvestrant in postmenopausal women who'd had prior both aromatase inhibitor therapy and mTOR inhibitor therapy. The exploratory group, subgroups suggested possibly a signal in cancers that are PIK3CA mutant, although this data is not conclusive from this trial. Importantly, the PIK3CA mutations were assessed both in the primary tumor and in the ctDNA, and some discordance between these will be shown later on this afternoon. The other group that appeared to benefit were patients with visceral disease. So putting this together, the higher rate of toxicity in the patients receiving buparlisib, including both the transaminases elevations and the mood disorders, may represent a clinical relevant challenge. However, prospective investigation of this P10 alpha selective PI3 kinase inhibitor in combination with endocrine therapy in patients whose disease progressed either on or before an mTOR inhibitor is warranted. And there is an ongoing study called SOLAR-1, which is looking at PIK3CA inhibition in PIK3CA mutant cancers. So thank you for your attention.
Ruth, were these patients subjected to some psychiatric survey or questionnaire or evaluation before going in the trial? You mentioned suicide attempts and all.
Yeah.
You know.
Yeah. So yes, in all the studies that have looked at this drug, there has been a very detailed questionnaire done prior to patients going into the study. So patients who had any level of psychiatric disturbance before going into the study were not eligible.
Okay. Thank you.
Hi, Neil Osterwell, oncology practice. I'd like to ask the panel members, Dr. Ardiaga and other members, given the low response rates of this agent and the adverse events seen in this trial, should it become available, would you ever use it?
Use what?
Would you use this combination?
Well, you want to start? Well,
good question.
Well, if you want me to start, I mean, I think that probably not. But I should not go beyond that and imply that PI3 kinase mutations are not a good target. Maybe what I learned from this is, one, that inhibiting all isozymes, PI3 kinase alpha, beta, gamma, delta, which is what these pan inhibitors do, may be a little too tough. Second, I think that it gives me an impetus to develop, as Dr. O'Regan said, PI3 kinase alpha specific inhibitors, because that is the offender, that is the isozyme that mutates and that becomes the driver in some of these cancers. Third, I think we desperately need a PI3 kinase mutant specific drug, something that would hit the mutant, that would not hit the PI3 kinase isozymes that you and I have in every other single cell in our body, which is kind of the problem. The problem is that you have a gene that is mutated, that is the wild type version of it. The non-mutated is part of very important physiological functions in all of us. So,
okay,
yeah.
Thanks. Anyone else? Yeah.
I want to echo what Dr. Arteaga said so well, and just say that I think that there definitely is a role that needs to be explored with these inhibitors, both in combination with other inhibitors like CDK4/6 inhibitors, combinations in HER2-positive disease, where I think there is real promise as we get smarter about testing tumors for these mutations and developing or identifying predictive markers of benefit. So I don't think this is a sad day for PI3 kinase inhibitors. I think it actually gives us a very nice view into the biology, which is promising.
Good, thank you. And just one more question, please, about the overall survival. You said the data were immature. Do you have, what's the longest follow-up, and when do you think you might have those data?
So there's overall survival data on about 40% of patients currently, so I suspect we'll get it later on in the year, next year.
Okay, thank you.
I would add another implication is that maybe PI3 kinase inhibitors that cross the blood-brain barrier, I think may not, is something that we need to be cautious about, because this affects these psychiatric effects, maybe on target from inhibition of PI3 kinase in the brain. So that's another implication from this data.
The molecule's too small? I mean, perhaps?
It gets there. It gets there. The studies to watch would be SOLAR-1 and Sandpiper. These are studies that are in the metastatic disease, ER-positive tumors that have enough PI3 kinase mutations enrolled. These are combinations of, again, endocrine therapy with or without PI3 kinase alpha inhibitors. Those are the ones too, and we should have data on those within the next year or so.
Thank you.
Thank you, Dr. O'Regan.
Thank you, Ruth.